RHD stands for rheumatic heart disease, and rheumatic heart disease is always a sequelae of rheumatic fever. Now, rheumatic fever it starts with a sore throat, which is a very common thing. And this is a sore throat caused by a specific bacteria known as a group B streptococcus. Now, the sore throat itself does not cause the heart disease, but what happens is that the body reacts to this sore throat by creating an immune response. And it is seen that this immune response then goes and attacks the heart. And then they have some cardiac manifestations. So, if you can treat the illness at the level of the acute rheumatic fever, you can prevent a lot of these patients progressing to the sequelae, which is the rheumatic heart disease. RHD varies depending on the locality, the state, and different parts of the country, unlike congenital heart disease. And RHD, over the last 2 decades, the incidence has come down. So if you look at studies from, say, the 1980s and early 90s, RHD was said to be present between about 10 to 11 per thousand population. Nowadays, it is estimated that it is seen between 3 to 5 patients per thousand population. And again, this is more common in areas such as slums where there is overcrowding, where there is poor socioeconomic status. So specifically, this is a disease which is very parallel to the development of a country and of a population, which is why RHD has almost completely disappeared from Western nations as they have become more affluent. And again, this is something which we don't see so much in Mumbai areas, which are urban areas. This is a condition which is seen more commonly in overcrowded rural areas. Acute rheumatic fever has some specific findings, commonest being it's a high-grade fever. Usually it will be associated with joint pain and swelling. There can be a rash, there can be some nodules below your skin, which are swellings, but the commonest is the joint pain and swelling. So if you see that, then you should rush to your pediatrician and they should work up for a acute rheumatic fever. Whether there is a cardiac involvement or not can be seen by examination of the patient, and we can also do an echocardiogram at that acute stage and then decide. Rheumatic heart disease is basically a disease of the valves of the heart. And if you know, there are 4 valves in our heart, and the work of the valve is to open to allow blood to flow in one direction, and then the valves close and the blood does not leak backwards. So the blood only flows forward. Now, of these 4 valves in the heart, RHD generally involves the left-sided heart valves, which is the mitral valve and the aortic valve. And it can either cause a blockage or a stenosis of the valves, or it can cause a regurgitation or a leakage of the valves. So whenever you have patients presenting with RHD, they will have common features suggestive of heart failure, meaning they get tired on exertion, they can have swelling of their body, of their feet, they can be breathless, maybe when they lie down, they start coughing. So these are general symptoms of heart failure. And then if you evaluate them, you can see specific signs that it is a RHD case. So signs would be a murmur in the heart. Each of these defects have a specific murmur, which is an abnormal sound in the heart. They can have an abnormal rhythm, so the heart rate can be very fast. They can have changes in their blood pressure depending on how much a valve is leaking. If there's a lot of leakage of the mitral valve, then you can have excess fluid in your lungs. So you can get specific sounds when you listen to the breathing of these patients. Of course, the final diagnosis is again made with the echocardiogram. So when we do the echo, we get a complete detail of which valve is involved, how much of it is involved, and what is the better treatment option for that. First stage of treating RHD is to optimize the medical management. and that includes anti-failure medications. We give a group of medications known as diuretics, which allows the patient to pass more urine and get rid of the excess fluid in their heart. And then we give other medications to control the blood pressure, which helps in the leakage. But ultimately, all medications are just to optimize the present condition. They don't treat the RHD. And the final treatment of a severely diseased valve with RHD is actually a valve replacement. So the surgeons have to go in, they have to take out the diseased valve, and they have to put in artificial valve. Now, this is, of course, at the end of the disease spectrum. The other end of the spectrum is when the patient just has an acute rheumatic fever where there is a cardiac involvement. And at that stage, if this is picked up at the correct time, you can actually start them on some steroids. You can give them anti-failure medications. And we see quite a few patients who don't even require the valve surgery later on in life. So again, it comes down to if you diagnose the heart defect or the RHD at the correct time, you can really change the outcomes in these patients. So the valve replacement most commonly involves putting in a prosthetic valve, which is a metallic valve in place of the normal valve of this patient. Now, the prosthetic valve is an external material, and the blood tends to clot around it. If it were to clot, then the valve will not work properly. It will get stuck, and then the patient again gets sick. So any patient who has a prosthetic valve replaced or has a valve replacement, they have to be on lifelong anticoagulation. So you give medicines to thin out their blood, and this has to be maintained at a particular level. So to maintain the correct level, you have to do a blood test every few weeks just to see that the blood is adequately thinned out, but not too thinned out. Of course, if you thin out the blood too much and there is no clotting, then they can have bleeding from elsewhere in their body, which is, again, that's another risk. So that is the main problem with a valve replacement. It is not per se the surgery, but lifelong they will be on a medication. They need recurrent blood tests to optimize the dose of the medication. If this is a female patient, then these medications are not recommended during pregnancy. So you have to actually change to a group of injections to maintain this anticoagulation during pregnancy. So it has a certain amount of follow-up required, and it does change the lifestyle of the patient in the long run. So older patients who are in their 40s and 50s, we have valves known as bioprosthetic valves, which are tissue valves, and these do not require anticoagulation. But we do not use these tissue valves in the growing age because it has been seen that there will be valve damage quite early on. So if you were to put in a tissue valve, say in a 15-year-old child, that valve will hardly last maybe 5 to 10 years, after which there is calcium deposition on the valve and it doesn't work as well. But older patients, yes, you can put in tissue valves, which work just as well. Now, in the present era, you might have read about the transcatheter valves. There is a procedure known as TAVI, transcatheter aortic valve implantation, which is done in adults. And in pediatrics, we have a similar procedure known as a TPVR, transcatheter pulmonary valve implantation. So these are procedures where you can put in a valve which is sewn onto a stent without an open heart surgery. You can go from the vessels of the groin and you can put in these valves. But this is not something which has been done primarily in rheumatic heart disease patients. These are basically procedures which are done in congenital heart disease patients and patients who have had surgery for their CHD. But if you have a bioprosthetic valve with a casing, then it is possible to actually put in a transcatheter valve also in those patients. The immediate surgical risk depends on the condition of the child or the patient. Suppose a patient is very sick at admission, even before their surgery, obviously that increases the risk of the surgery. Overall, if the patient is stable, then the immediate risk of surgery, I would say, is less than 5 to 8%. Long term, as long as the anticoagulation is maintained optimally, these patients do well. So a patient with a prosthetic valve can lead a near normal life, but they have to get these multiple blood tests to maintain that anticoagulation. Also, if you are on anticoagulation, you have to restrict from very heavy exertion. For example, you don't want to be playing football because then you'll get a lot of bruising. That is the main thing. So if it is treated at the right time and the heart itself is working all right, then these patients do well in the long term. So we do a blood test known as a prothrombin time and an INR. INR is standardization of the prothrombin time. So you can do it from different labs and you'll still get a value which is comparable. And the frequency depends on the age of the patient and what is the INR level. So ideally, let us say for a mitral valve, once you've put in a prosthetic valve, you want that INR to be somewhere between 2.5 to 3.5. So as long as your blood test is showing that level, you can maybe do the next test after a month or so, or even 2 months. But if the blood test is less than or more than that level, then you have to adjust the dosage. And once you've adjusted the dose, then you have to do the INR a bit earlier to see that you have got it right. So I generally ask them to do an INR after 7 to 10 days of a change in the dose. Now, what we generally see is that it is much easier to maintain the INR and the dosing in an adult patient compared to a pediatric patient. So some of my pediatric patients who are on anticoagulation, they might be getting an INR done every 2 to 3 weeks, whereas the adult patients might be getting it done every 1.5 months or so.